Hi, I'm Phil Sabatini. I'm sitting next to Dr. Justin Griffin and Dr. Jake McCrowell. And we're going to discuss shoulder surgery that I had 7 months ago after the Weightlifting National Championships.
So what we're going to start off with is really the initial onset of the injury, and we're going to just kind of play it forward, and so people kind of understand a little bit more about that condition and how we diagnosed it, how we got to the point that we needed surgery, and we talk about the first parts of rehab, and then we're going to answer some questions that some people had. So first, Phil, why don't you tell people you're lifting, I think it was your second snatch? First snatch. Mm-hmm. Tell people kind of what you felt, what you experienced, and we'll kind of go from there.
Okay. This was at the National Championships in May, which was 7 months ago. I went out for my first snatch, which was 150 kilos. And as I was going overhead, it felt like the barbell was moving behind me a little bit. So as I attempted to stabilize it, I felt a little bit of a pop, but no pain or anything like that. And I stood up, stabilized it, I made the lift. As I was walking off of the platform, something just didn't feel right. It felt like there was air underneath my arm. It was just, something wasn't right. I tried to high five one of my coaches and could barely really lift my arm. And I remember going into the back room, and you gave me 5 and everything, and I said, I think after this I'm gonna need extended time off. And you said, why, what's up? Yeah. And he started checking things out, and obviously I could see on your face there was a little bit of concern, although you tried to hide it fairly well.
Yeah, so there was definitely a certain amount of concern when we went to do initial, some special tests and some range of motion measurements. Before I go into that, Dr. Griffin, what can you say about that mechanism of injury and how that potentially leads to, the rotator cuff and the labral tears that he had?
So first, thanks guys for having me. And I think that one of the things that goes into that discussion is really what does the rotator cuff do, especially in an overhead or a high-level athlete? How does it function? And so I did bring with me a shoulder model just to show what the rotator cuff is and really what its main function is. And so we have a couple of components of the shoulder here. The first being the bones, and that's the humerus bone, which is the ball, and then the socket side. Those are really all sort of held together and function through the rotator cuff tendons. And that's 4 tendons around the shoulder that help you to have the best range of motion of any joint in your body. But they also have very specific functions. And one of the things that we see in many of our weightlifters or overhead athletes is that when their shoulder goes into a particular position, it can lead to an injury to the rotator cuff. And some of those injuries are very small. In Phil's situation, obviously, he's a highly trained athlete, and so this was one particular motion where there was a high degree of weight on the overhead position, and many times that's what leads to an injury, is this overhead position where the shoulder may actually slip out a little bit or have a subluxation or even a dislocation event that can lead to a tear. And so in his case, this was on the more severe spectrum of a tear, but many of these are more just impingement of the rotator cuff or other smaller injuries that can be managed without any kind of surgery.
Yeah, I think it's an important point to say. From my understanding, I think what the research shows is like almost 90% of rotator cuffs are going to be repetitive in nature, mm-hmm. or impingement in nature, like you said. And then you have a case like this where you go into an extreme amount of weight going through an extreme amount of range of motion and taking the shoulder kind of out of position to lead to that, taking that tendon past its tendon capacity. So kind of to pick up where Phil left off, Phil came back, and the first thing we noticed is that he couldn't lift his arm. So that's a pretty good sign that something's not right. We broke down a few other special tests and did some other range of motion and strength testing. I don't know how else. Do we want to go super specific on that? Really, we had several tests. I think it's important to know that when we try to funnel our clinical decision, I want to have multiple things to funnel my diagnosis. So when we saw Phil's shoulder, most importantly, some of the tests that we know that are very sensitive and specific at picking up certain pathologies like a rotator cuff tear were indeed positive, and we saw specifically one test that kind of looks for a full complete tear was positive among testing and range of motion and some other testing that we did. So that kind of gave us the idea that, or the diagnosis that we had a complete tear. And then from there it was really kind of a decision of, what do we do moving forward and how quickly do we get this under control. When you have a complete tear, and then Dr. Griffin, you can definitely pick up here. When you have a complete tear, I want that person to see someone as soon as possible so that tendon doesn't start going away from the attachment site. We want to get some confirmation, whether it's through imaging or through the eyes of an orthopedic surgeon, to confirm that diagnosis. So as soon as the lift, the meet finished, then I kind of broke the news to Phil. Said, you did great, but I have some bad news. I think we have a complete tear, and we got to get this under control incredibly quick. And that was, I believe it was like Memorial Day weekend. So we were very fortunate to reach out to Dr. Griffin, and really we had him in the office on Tuesday, which I think is a testimony to what Justin does, and then went surgery by Friday. But can we talk about basically me reaching out to you and saying, this is what I'm seeing, and what you saw when you saw him on Tuesday, and what led to surgery on Friday?
So I think that really going back a little bit, I think one of the big questions that I often get is, how do I know when I should see someone? If I have a shoulder injury, what's the things that would drive me to seek medical attention? Because it's not always that you need to see someone. Many cases, these things will just get better. And there's plenty of patients that I see that have just a bruise of their rotator cuff or a contusion where they bring their arm into this position, which is a position of risk for the shoulder in many ways, and they'll have some pain. And my feeling on that is many times patients will schedule an appointment, but then they're better in 3 to 4 weeks. Maybe they saw Jake, maybe they saw Phil, maybe they saw someone who is in their sphere that they then got better. And that's best case scenario, because if they cancel that appointment, that's perfect, because they didn't really need anything more than that. But in the situation where the shoulder continues to hurt for 2 to 3 weeks, that's really where you may want to think about seeing someone and having an evaluation. And so at first when I saw Phil, what I noticed was his profound weakness. And for a guy like Phil to have profound weakness is a big deal. And so one of the things that was most impressive was just the inability at that time for him to hold his shoulder in any position that he wanted to. And so for me, when I see that impressive of a physical exam, I'm pretty aggressive with an MRI for someone in Phil's situation. That's very different than someone who has a little tweak of their shoulder, they didn't have a significant trauma of any sort, and they just have pain that came on all of a sudden, or more of an overuse pattern, as you talked about. And so I think that one of the big things is, what's the degree of the injury, what's the major deficit, and then what should be the next step? Should it be just, let's try some physical therapy for a while, which is in many cases, as Jake and Phil know, that's really my preference, is let's see if this gets better before we go and order expensive tests. Because ultimately, what really matters is the patient and their symptoms, and you probably know what's going on well before we even have the MRI.
Yeah.
So I think in Phil's case, the MRI was critical, but
it's such a special circumstance.
It is.
I'm glad you kind of said that, because I think we're talking about a special person in a special scenario here.
Exactly.
And of how it was handled. So I think it's worth definitely mentioning and repeating that, what we're going through and what Phil went through specifically is not your normal course of action. But we saw something that was so severely torn at the time, and such a traumatic injury that it led to a kind of a quicker response.
Yeah, and what we know about traumatic tears specifically is that the earlier in a young person with a complete tear, the earlier you can address those, the better their muscle may function in the long run. And so we can get into some of the details of that if you want. So if we look at the shoulder again, there's 4 rotator cuff tendons. The one on the top, the supraspinatus tendon, is the most commonly torn rotator cuff. And then second to that is the infraspinatus, which helps you to rotate your arm out to the side. These two tendons, when they do tear, many times they're smaller or partial tears. Most of the time those can get better without surgery. But when you have a traumatic tear like Phil's, his involved the whole tendon of the supraspinatus as well as the infraspinatus in the back. And this was a particular pattern of a tear that was suggestive of a traumatic injury like he had. And so even though we got to your surgery 3 days later, the tendon was already pulled away from the bone in such a way that it was even a little bit tough to get it over. And that's the response of really the muscle quality that he had and the high energy nature of the injury. And so there's many ways to manage that. Certainly in some of our older patients, we'll try other things first, but for what Phil's goals were, that wasn't going to work. And so what we had to do in this situation is really to restore that back to the rotator cuff footprint. So we do that with a small camera which goes in the back of the shoulder, and it's called an arthroscope, and it's done outpatient. And so for Phil, that's what we did, is we did an arthroscopic rotator cuff repair.
So you had the surgery that Friday. Talk me through the first week, like physically, how you felt, mentally, your expectations of a rotator cuff tear, or excuse me, the repair and that process. And you have a long road ahead of you, so sometimes it's almost a dark place, and I don't want to bring you back here, but like how that first week or two, like how was it physically and mentally for you?
It was challenging, but typically after a big meet like the national championships, I take extended time off. I'll take 2-3 weeks off from training just to mentally get a break. So when the surgery occurred, came at a really good time because I was ready for a break to begin with. So in terms of competing and training and things like that, definitely wasn't at the front of my mind or anything like that. It really wasn't until 2-3 weeks later when I'm in the sling and that thing doesn't come off, that things became really challenging mentally in that regard. But the first week after surgery, it was just about recovery, and I was just fine just doing that. But I think what was really good just mentally was seeing you, I think within 2 days or 1 day, either 1 or 2 days post-surgery, I came to see you, and we did a few things, and I think that was really, looking back on it now, I think that had great magnitude because I immediately felt like I was taking progressive steps and positive steps. And somebody like me, and high-level athletes just never want to feel like they're taking steps backwards or even just being in the stale. So even though I had a major setback, it still felt like I was on the right track to getting back to where I was. So I think that was really instrumental. My biggest challenges came, we were 7 weeks, I believe, in the sling, and that got old.
Just lasers in your eyes. That's
6 weeks. 6 weeks. I'm sure it felt like 20. I'm sure it felt like 20.
That was really challenging.
One of the things I remember is the morning of surgery, I said, to Phil, I think I said something like, Phil, you had this huge tear, which we knew at this point was a massive tear, and you still got third in nationals. He goes, second.
I was about to correct you.
So I would just say that's another thing just to say is that he had an amazing result from his hard work, but this was a really big tear, and there's tears that we worry about more than others as surgeons, and his was one of those. And so just to give you an idea, he had all those tendons off, and that required a combination of 6 anchors just for the rotator cuff alone to fix that. And the typical tear might require 2 or 3 anchors to fix the rotator cuff. And so this was a very big tear that was one that I wanted to make sure really healed. So we know, just getting into some of the biology here, that the tendon takes 6 weeks to really regrow into where it belongs on the bone. And before that, you really can't say that the shoulder is going to be okay to move out in front of you to lift objects. And so that's not as much that I wanted to torture you as it is that we really have to wait for that tendon to have enough of a blood supply and to grow into the bone enough that we can all feel comfortable with you using the shoulder and rehabbing it. And that's one of the most challenging things for our patients is sleeping in the sling is a challenge, and recovering from this surgery. This first 6 weeks are really hard, really hard.
So first, on a side note, I remember Dr. Griffin saying like it was just so hard to get through his bone. It's like it had so much. So how to use like whatever you normally use.
So I always joke around that we don't walk on our hands, but Phil kind of does. He carries more than his own body weight over his shoulders, and so when the bone feels that much stress, it gets harder and harder. And so we had a unique situation where his bone was very, very hard and very challenging because of that. So he's happy to hear that.
Yeah. Well, I remember you explaining how it took much longer than you thought it was because you had to actually go get the drill and drill in to get the anchors to actually get into the bone. So
Staying
I
on
felt
top
pretty
of
good
your
about
arm.
that.
Specific adaptations to impose
That's
demands
right.
at its finest. Yeah, Wolf's Law at its finest.
Because that is really what we do is we put in these little anchors, not metal anchors, but they're a bioabsorbable anchor that goes into the bone, and they have special sutures that are put through the tendon to sew the tendon back where it belongs. And so that's how we repair the rotator cuff. And as much as I'd like to say that we can speed up that timeline, that's one of the biggest challenges with rotator cuff is the biology. That's an area that has a harder time healing, and we have a lot of things like that are out there, such as PRP or stem cells and other things that we can do to stimulate that healing process. But the reality is that timeline, we can't rush the biology. It just is the way it is for that 6 weeks.
For sure, it's the limiting factor. Sometimes I describe it to a patient as, if you had a bruise on your leg, you can do everything right, but it still takes maybe a week for that bruise to go away, and you have something much more severe than a bruise going on right there. I like to go off one thing you were saying, Phil, about like the first week. I think as a physical therapist, something that was really important to me was kind of set small objective goals. And something I do with my patients is we try not to shoot for, all right, here in a year we want you to lift in nationals. We want to have the long-term goal, but we want to have all these small little goals. And so you can see how, well, you need to get this much range of motion so we can move on to the next goal. So you just have these little steps, and you have these constant opportunities to achieve them, and you see that success. It's easier to kind of stay motivated and stay focused on the bigger vision. So I think it was really important for Phil and I in the first week or so just to really be diligent about goal setting, as much as it was about passing range of motion and waiting for the tissue heal. Is for you, I think physically and mentally, it was just about really goal setting. And for me, goal setting is just about really small little rungs on the ladder and being very progressive with that for a patient. And I think that was really helpful for you.
Yeah,
and I think another part that to go off it for you is it's not just the therapist making the goals. It's not just the surgeon making the goals. I think it's a team making the goals. And I want the patient, I want Phil to be involved with how that goes. And we can say, well, maybe we got to back up that goal, but it's much more interesting you're gonna get better outcomes and more buy-in when we have someone who's actively involved in making their goals instead of just someone telling you the goals, as it were.
So I guess one thing for both of you would be, having been through this, and you obviously go through this quite often with patients, and what do you think of as the timeline? I think one thing that people always ask is, when can I begin strengthening? When can I begin cardio? When can I begin true weightlifting? And just sort of maybe talking about your timeline. Is that okay to do now?
Yeah.
Just to talk about your timeline for when you went through all those things, and Jake, obviously your perspective, and go from there.
Yeah. So, the question would be, where after maybe the 6 weeks, we're out of this thing, we can start slowly progressing things. What are the expectations for the patients? I try not to put a specific date on it. It's a range.
Sure.
And it really, I hate to, the first part of the answer would be, it really depends.
Right.
And that can vary by months.
Right.
It will go back to what I was saying previously is, well, you're not going to earn the right to strengthen yourself until you've proven that you have this type of ability. You're not going to be able to do this type of lifting until you've proven that you can do an easier, more fundamental movement pain-free. So I want that athlete or that patient to have a certain amount of a fundamental capacity of mobility and motor control before we start introducing strength and some of that functional loading that you were mentioning.
And I think when you look at Phil's early things that he was showing on Instagram, once he got out of the pool on vacation,
Yeah,
I remember seeing Phil
I know
with his steri strip still on in the pool on Instagram and being mildly worried about that. But anyways,
I get a call from the
Yeah.
surgeon telling me, what
Right.
are you doing?
Right.
And I get to call the person and go, hey, try not to hurt a relationship here before
but I would say that, you know, what you see in some of the early things that Phil was doing was a lot of isometrics and a lot
Yeah.
of just focusing on balancing of the shoulder, which typically we wait on for a period of time, not really beginning a lot of strengthening until we get out to at least 8 weeks, and that means light strengthening, isometrics, focusing on isolated movements.
Yeah.
So I think that's a really important thing from a therapy perspective that Jake does an excellent job at, is focusing on those small goals, trying to really retrain the muscles because they haven't functioned for a period of time.
Yeah, we have one question here. It's basically what, like, after the 6 to 8 week period, what was your primary focus? Was it range of motion or strength or both? And my answer was more focused on, like, it's more about the mobility, but we didn't rush strength. That was a super important concept for us, and part of this was we're going to focus on isometrics, and we're going to focus on motor control, we're going to focus on muscle activation, and then instead of being too focused on strength. Strength will always come back. It's just, we have the time to build, and we know from your exercise physiology background, and you can speak on this as well as anyone, that true strength takes months, 6 to 8 weeks to start seeing those strength gains. So we knew the bigger, the more important concept here in that 6 to 8 week period, and even 8 to 12 weeks when we start introducing some light strengthening, was to be focused on motor control. So we weren't rushing strength overhead. We were more focused on range of motions and positions that were less aggressive on the shoulder and more effective on trying to get the right motor timing and muscle activation. Some of our patients sometimes wonder, like, what actually a rotator cuff repair, what's that all about? Like, what's going on? What actually is the time and place to get it done, and what does a surgery entail? So can you elaborate a little bit more on that?
Sure. So there's a huge spectrum of rotator cuff problems. When we look at patients, the typical patient that you hear about having a rotator cuff repair is not Phil. Many times it's patients who are much older that have long-term, kind of what we would term wear and tear, and they will have a different type of tear than Phil had. Phil's was a very large traumatic tear that happened in his sport, but many patients have just partial tears where they get some fraying of the top rotator cuff tendons, which are the tendons that really cuff or surround the shoulder to help it be lifted. And so if you just have some partial fraying, many of those patients' tears will heal. Actually, 30% of them, if you look at the literature, will heal without needing surgery. Another 30% will get bigger, and then the rest of them probably stay the same. And so most of the time we'll try with our therapists and other patients to really decrease the amount of surgery they need by trying something like an injection maybe if they need it, or just the physical therapy alone. There's pretty good emerging research that repeated injections for rotator cuff problems is not a good idea, and it may lead to a worse outcome in the future. So if patients aren't getting better with a good course of non-surgical treatment, that's where we think about rotator cuff surgery. And modern rotator cuff surgery is a minimally invasive approach to the shoulder where you have 1 centimeter poke holes around the shoulder, usually 3 or 4. The arthroscope helps us to see inside the joint, and that's put in through the back of the shoulder, and then you can see everything that you need to see. We'll mobilize the tendons over to the footprint of the rotator cuff, the tuberosity, which is the bone where the rotator cuff inserts. And then we'll put small little holes into the bone with an anchor that has a special suture in it to then sew the tendon back to the bone. For big tears like Phil's, we often will use what's called a double row repair, which is the strongest type of repair that we do. And then for some smaller tears, you can sometimes fix those without needing as many anchors or as many sutures. So it's all should be done arthroscopically. It's incredibly unusual that a rotator cuff would ever have to be opened. I hear a lot of times that patients said that maybe their tear was so bad that it had to be opened for surgery, and really there is no rotator cuff that should be opened necessarily in 2018. There's pretty good research that arthroscopic repairs do much, much better.
That includes a subscap?
For me, yeah, I would tell you that there is a very rare case where a tendon is so atrophied and retracted away from the bone that it can require a repair to be brought over, that it's very hard to do that arthroscopically. And that is a situation where certainly if your way of getting the best result is to open that subscap tendon, then that makes sense for that surgeon. But I would say 99.9% of the time, even the subscapularis can be very nicely fixed arthroscopically. We have a good paper showing the technique of that and how you do that. It's very reliable for most patients.
So if a patient goes in, has surgery, how long is that how long does that procedure take for you to do?
So a typical rotator cuff repair is done on an outpatient basis, and so for Phil, we come in the morning, and they do a block so that the patients don't have to go to sleep for surgery. You're awake in what we call the beach chair position, which is where you're sitting up like this, and then the repair is done. It takes about an hour and a half or so. Usually somewhere between an hour and 2 hours once the surgery time is started for a full thickness tear. If it's something smaller, sometimes it can be more like 30 to 45 minutes for the actual surgery. If there's labor work to be done, such as in Phil's case, that can take a little bit longer, but the general surgical time is somewhere around an hour to hour and a half or so for the surgery. And then the patients go home in their sling, they wake up with their bandage in place, and then the sutures come out in about 2 weeks. And many times we have them visit with their therapist after 2 days to help with the first dressing change, to start some pendulums where they're hanging the arm down, but we're pretty careful at protecting the repair for the first 6 weeks.
All right, so here's a good one. And this is actually really in all of our opinions, but what's the number one contributor to a good recovery? I'll ask you first, Dr. Griffin. And I know that's sometimes these questions are always tough, and online you're gonna see like, what's the one exercise that got you better?
Right.
You know, it's like everyone wants that simple fix, and it's not that. But what are, maybe we should say, what are a couple contributors that maybe people don't think of, or they think of, and it's worth noting the importance of them. Like, what contributing factors do you consider? Also, from a surgery standpoint, when you go, well, this is definitely like what contributes to a successful surgery, or what are some factors that have been shown to lead to success for rotator cuff?
So I think from my perspective, our goal is to regain a painless, functional shoulder. And so that really encompasses multiple things. First of all, a patient who is healthy and who takes really good care of themselves nutritionally, they're compliant with what you've asked them to do, those patients are going to do very, very well if you give them a stable repair. So for me, a stable repair, meaning if it's a very repairable rotator cuff and you repair it well, that's step one. The second step is having an excellent team. So I think this is a team sport, a team approach, just like anything we do. 70% of someone's outcome is what happens after surgery. And that's having Jake, having Phil, who's been compliant with the restrictions, who's gonna take good care of himself and and eat well and have a good protein diet after surgery, and then do the physical therapy. I think those are for me, the formula for success is an excellent team, and then a stable repair in a patient who has the biologic aspects that are going to really help them to do well.
Phil, what do you think is like some of the main contributors?
From an athlete's perspective on his patients, I think it's really challenging to stay doing very similar exercises for weeks at a time. It's just not something that someone who trains on a daily basis through years of progression is used to doing, and so that was really challenging. And I just think aside from that is, as you mentioned, the team. There's so many questions that can be asked, and it's better to ask them than to make a mistake or to just assume that you can or can't do something. And I think there's hope out there too from the athlete's side of things, that there is such a thing, I think, as doing really well with your rehab and being rewarded for that. And that's how I felt when working with you. Is like we had these benchmarks. I wasn't allowed to do this until I completed this exercise the way it was supposed to be done, pain-free with the right mobility and stability. And once I reached those benchmarks, then we progressed it, and that became the new challenge. And so I think that really contributes to a progressive rehab is meeting those goals, setting those goals, and having things that are in place to feel like you're progressing.
Yeah, I think it's important for me that when you hit a goal, it was immediately like, okay, here's a new one. Like we're not going to take much time to celebrate this because we're going to move on to the next one. But I think that's part of your mentality. For some patients, I think you need to enjoy the process of having success, and you spend some time there. For some patients, it's like success has been met, boom, next thing. But it's being really clear, and that's to me one of the biggest contributing factors of our clarity of like, this is like, you have to show me you can do this to move on. And I keep saying like, it's kind of a vague, but it's because we did it dozens of times. Of just, you need to show me you can do this with your range of motion to do this. You got to prove to me that you're worth doing that next step.
Yeah, another thing too, from your standpoint, is that I would say that you were fairly aggressive with it. I would say that you wanted to try some things. You wanted to see if I could meet some of these benchmarks, and there were times that I couldn't. And we both had to accept that and say, it's not there yet. I bet you by next week it might be. You know? And sure enough, like I remember a couple times with the lightest band that you had in there, wall slide. Nope. And then sure enough, what seemed like 2 or 3 days later, it was there. And so it's just it's crazy the way it goes, but.
And I think what you're alluding to is there's this perfect balance with what you do post-operatively of providing hope, but then also reeling back if things are getting a little bit too aggressive, and knowing when to sort of take things back a notch, but also still provide that, hey, we're going to get there, this is going to get better. And that's a really tough balance, and one that's very challenging to strike.
I think that the clinical pearl that I would say is every exercise is an assessment to me. Every assessment is an exercise. But like every exercise you're doing, you're not walking out of the room and saying, let me know how that goes. Like we're watching every rep and going, all right, well, you did 5 reps, the goal is 10 reps. So sometimes it's as simple as that, but we can be really quick about, okay, that's not working, what's our regression? And I think as a therapist, you're like, what's the best exercise? It's an exercise that you're comfortable with progressing or regressing. And get people on all fours and do like quadruped exercises, and there's 50 ways I can progress and regress it. The same thing for a wall slide. There's so many little different nuances that we can do to, okay, well, we can't do that. Let's not hammer something let's hammer a square into a circular hole or whatever. Let's find the right amount of exercise that will fatigue you and challenge you, but that you can be successful with. So I think it's important to try exercises and try techniques that go, okay, well, it's not successful, and being really quick, or like being, okay, that's fine for the patient to see that too, because that's the reality, that's our next step. So it's a balance. And when we talk about progressions or we're talking about making goals, I think goals aren't always linear. There's times that it kind of goes up and down, and as the big picture, it's going up, but it's really going up and down like that. So and that's part of the therapy too. It's part of, even right now, we would have a great training sessions, and then next session it would be a little bit more sore, which is in the range of motion, despite doing the corrective exercises and mobility work. But linearly, we're getting there. So it's important to kind of be able to catch something really quickly and be able to modify it appropriately.
Yeah.
Is there any type of part of the therapy that you were really excited about, that you really enjoyed? Maybe that's a better way of asking that.
I'll just step in a second and say, I'll never forget when Jake texted me, you said you should have seen Phil do his first squat. He couldn't get the smile off his face.
That's true. We also would text Dr. Griffin and be like, man, he's just having really tough, like really early on. Like,
right.
I can't get his press, like strength motion strong enough. He's like, what are you doing?
Yeah.
So we kind of pulled each other's tails there a little bit. But yeah, that's definitely a good answer. Yeah. But yeah, what else? You think you can add?
For the key exercises.
And not just key exercises, but maybe exercises that you did that you're like, oh, I can see like this is a big step in my progressions, or like I can see how this is bringing me back to my functional movement, which is snatching and clean and jerking.
There were a few moments throughout the rehab that I felt like I was, it opened my eyes to the progress that was being made, you know, and I think the first one, some of the earliest exercises that you had me doing when we were progressing the isometric stuff, I remember having a band and I would just walk out, and I would, you know, so that it started isometric, and that's all it was, because in the beginning I was just doing that up against the wall. But then we added to it, and I was walking out against the band, and it was adding resistance, and I noticed that I could walk a little bit further, I could hold it longer, my eccentric was much more controlled, so I could actually feel the strength increasing, and the pain wasn't as bad, nearly as bad, as things progressed in that regard. So that was one of the exercises I would say was sort of a eye-opening. I don't know if you would call it a benchmark exercise, but I could use it to test, you know, the strength of the rotator cuff and stuff like that. So that, I would say that one was one. We did a lot of like mobility stuff. I can think of one on the ball that you had me doing that was like assisted. I'd use my opposite arm to help pull the other one overhead, and I remember getting more range when I actually could put that over my head in flexion. I was pretty happy about that. And then of course the ones that everyone would assume, just being able to press the first time. I remember when I cleaned for the first time, and you had me jerk the bag with the water in it, and that felt really good. And you know, along the same lines, I remember snatching for the first time, and as excited as I was about it, it didn't feel great, you know. So it's just it was so long since I've done it.
I think I was more excited about your first snatch, actually. I remember.
I wanted to get excited about it, but it was at the same time I was like, oh man, like it's just it wasn't the greatest feeling, you know. Yeah.
I think what you're speaking to is really that this it's a challenging recovery for what you recovered from, and the shoulder is pretty complex. You know, there's 17 muscles alone that attach on your scapula. It takes a while to retrain all that. And as well as the inside of the shoulder could be with the repair, it's going to take a while before you kind of regain that muscle memory. It's going to take a while before you really feel comfortable. And that's that last 25%, which is where you are now. That return to sport, the last 25% is physical, but it's also, there's a mental aspect of this too. Once you get to the point where you are now, where you never return an athlete at 100%. That last 25% always comes, you know, in the next step. What are your thoughts on that, Phil? What do you think about that?
Oh, I will say that I've been, of the 7 months of the rehab, the most challenging part has been the most recent. You know, this last 25%, because I feel physically ready to do many things, but it's still just not exactly where it was before, or where I would like it to be now, and it's close, but it's just not there. You know what I mean? And I know that, and I know that we're still way ahead of schedule, and that there's plenty of time. And it's just that I would say mentally has been really challenging and frustrating.
That's a tough thing for I think a lot of patients. I always say like it's to get from 90 to 100% is the longest period. So we're talking about things being linear. It's linear, but it is like you have to be really backed up to see it going
and
on.
I felt like the progress that we've made the past 6 months was really fast and
and I would say that that's very true, that if you look at rotator cuff rehabilitation, where you are at 7 months is beyond where most people will be with your same tear, with a 2-tendon massive rotator cuff tear with a labral repair. You are well ahead of the schedule, as I've told you all along. And if you look at the world's literature on rehab from a rotator cuff, most people will quote a 100% recovery rate somewhere between 9 to 12 months. And our studies support that. If you look at outcome data from a rotator cuff repair, it's going to be 9 to 12 months that you're still making gains. And at 6 months is when most people, if they're not doing what you do for your sport, most people will be back to everything they want to do, whether it's golf or tennis or other things that don't require the amount of stress on the shoulder that what you do does. But that last 6 months for you is the most challenging and the most critical because of what you want to return to.
All right, so we have time just for a couple more questions.
Were there times that the surgeon and the PT didn't agree, and if so, who did you listen to? And we made a joke about that because I didn't listen to anybody. But
We can both tell him the same thing. He goes on
me, I listen to me. Were there times that you guys didn't agree on stuff?
I don't believe so. I think there's times that it was just like there's phases of like we're getting out of the 6 week phase, we're getting out of the 12 week and 10 to 12 week phase, and we're kind of transitioning to active motion, we're transitioning to strength, or we're transitioning to function, return to sport, that we want to be I guess consistent with what the research and what physiologically we can do. No matter how strong everything else is, we have to respect the healing process and the physiology of how tissues repair. So I think Dr. Griffin is a good. It was more of a resource of saying like this is like what's going on. Are we okay with that? And it was more of a support structure than a like management in that way. So I think that's I don't know if that's the trust he has in me, or which probably is I don't know if that's good or not, but
doubtful.
Yeah. So I don't know. I can't think of a specific time that we particularly disagreed on anything. And I think there's times that you want to do a little bit more. I think it was a trust system of saying, look, this is you said like we're going to be aggressive when we can be. So I think it's important for the patient to understand like we're going to be aggressive but smart. Like we're going to know when things aren't working and we can immediately back it off.
Yeah, it's one thing to say we're going to be aggressive, we're going to do this, and this by this time. While that may be your goals, again, going back to what we talked about already, that only took place because I was able to pass the tests that you put into place.
So I think linear goals are better than having like, well, we need to be here by 6 weeks or like here by 12 weeks. It's like, well, we just follow the steps. They just kind of meet up at the same point anyway. So I don't know if there's any.
Yeah, I think what really the question's a great one, which is who is sort of the guiding member of the team and who is the person who's the decision maker on terms of what happens. And I think in reality, it's a very much a team approach that you respect everyone's perspective on it. We had a physical therapist, but we also had a professor who has a lot of knowledge of the body and of training. And so all those are resources that if we're not exploiting those different areas of expertise, it just isn't going to get the best result for you or our athletes. And so I think that you spend a great deal of time with the patient after I have this very important moment at the time of surgery. And that for me is about communication, that I want to know what's going on. And I think for me, the communication is key between Jake and myself, and I think that really promotes and enhances care of athletes, care of patients after they go through something like this. That if you don't have that open door policy to say, please come to me if you have any questions, I don't know that you're always going to feel as confident about what you're doing or get the best results.
I think it's a great point. I think it's a point worth restating is if you're going to have surgery, I think it's important to ask. I always tell patients, you're going to have surgery, you need to bring some questions with them, but a question that is worth asking your surgeon is, what's your relationship with the PT? Mm-hmm. Is it easy enough for you to modify and talk to the therapist?
Right.
It's a lot easier for us, and I think that's part of the success is that there is open communication, and just a willingness on Dr. Griffin's part just to constantly just how much he cares for his patients, which I think is above any other orthopedic surgeon I know in this area. How much he's willing to he's bought in, or he's really invested in your goals. So that's an important concept to ask surgeons, or how invested can you get with the patient, and part of that concept, or part of that way to be invested, is making sure that they have a comfortable relationship with that PT. And the same thing for a PT. If I'm referring someone out, like, here's someone I know we can trust, and who we tell patients that aren't knife happy is a word we like to use. Mm-hmm. Like just because we can't figure this out, or we're not having success, here's someone who can give us some direction, and it doesn't immediately mean surgery.
Right.
So we'll finish with this. Phil, what's your perspective as an injured athlete, how it's changed your coaching philosophies and coaching skill set?
Bunch of different ways. Just first, learning new exercises, gaining a better education of the upper extremity, and different things about like what to do to gain range of motion in certain areas and stuff like that. Like, I felt like I picked up on so many different things on so many levels in that regard. But I will say that this is my first injury of how many years of being a competitive athlete. Yeah. I mean, almost 20 years as a competitive athlete. Yeah. This is my first real injury, so it was really challenging. But I've really learned a lot about the psychology of it. And I have more empathy for the athletes that are going through it, and so I think that's a really valuable experience for me as a coach.
I think it's worth one point that maybe I want to consider for athletes who may be trained by themselves or think about having a coach, is that a coach helps not just give you maybe a physical aspect, but they provide such a mental aspect of your training. Know when to tell an athlete. Another friend is a great running coach, and he knows when to pull someone back from you're running too many miles, and when to take an athlete and go, things don't look right, we need to change and modify. And it's kind of tough to do on your own, sometimes subjectively, and sometimes to kind of trust. It's tough to trust yourself, because you just want to kind of keep pushing yourself. But as a coach, or having a coach, you have that ability to have someone can kind of give you the best advice for where you're at that week. And just like we talked about, things kind of change, and we have to be able to look at athletes and modify things when appropriately. So I know I've treated some of your athletes, and I've been able to see how their program gets quickly modified when something's going on. And outside of you trusting me to see them and giving you some feedback, it's also here's an athlete that's getting a modification, so they're not going to make things worse or injure themselves in that process of trying to figure out what's going on, which is, I think, is really impressive, but also, the push. Not that everyone absolutely needs to be coached, but the vast majority of people could respond really well to it. For their perspective, sport, and their specific, their goal or endeavor in that.
So along with that, Phil, what do there's a lot of people who are interested in starting sort of Olympic weightlifting or CrossFit or some variation of that, and many times those are patients or athletes that haven't done it for a long time and they're starting up. What's some like advice that you could give to people who are interested in getting into it? Is there an initial kind of evaluation that you would do, or something that you would look like at a mechanic standpoint, that like the best way to kind of get started in that?
I think there's a handful of different diagnostic tests, if you want to think of it that way, exercises that we like to use to assess whether or not we can progress some things.
Yeah.
Just basic things like an overhead squat or even a front squat, or depending on the person, it could be even just a basic back squat. Now, I will say that, just from a coaching perspective, one of the best things that you can do as a coach is be able to modify activities based on things like strength levels and mobility levels. How can an athlete actually progress to get to the levels that we want them to if we can't find exercises for them to actually progress to get to that level? Right. And so, we might have athletes that can't get into a full squat position correctly or go overhead correctly. For that, maybe we use power movements, or we do things that are above parallel, with the hip and the knee angle. We don't go overhead as much in a snatch grip position, or maybe we do, but we don't add a squat to it. But all are ways that, like, in my opinion, that they're creating this new neurological education that's going to lead to more mobility and more stability and strength, that is going to make it much easier for us to progress those exercises down the road, and it tends to happen a lot faster that way.
Well, Dr. Griffin, thank you for your time. Appreciate you being here. Phil, thanks for stopping by.
Thanks for having me.
Yeah, appreciate it. Cool.
I miss you guys.
Yeah.
How about it?